Okay, so thank you very much for staying. And Claire, thank you very much for giving up your Saturday to come here this morning. So Moo's painted a really rosy picture for you today. But if we were really being honest with each other, the current state of play as far as response assessment is not that rosy. I showed you yesterday that the currently available tools that we have, for example, for detecting metastatic disease in bones, are really not good enough. As a result of which, what we think is M0 or no metastatic disease is actually M+. And Moo showed a very nice example of that. Liver, for example, where you use CT, you see something getting better, you use an MRI, and it's like a lot worse. It's a completely different answer. So when you talk to clinicians about that sort of thing, sometimes they don't care. And honestly, they don't care. Because let me show you an example. So here's an MRI scan. Somebody's getting abiraterone. Now, this is a really expensive novel therapy, as Moo was saying. You know, this is £5,000 per month. So that's, in the US, that'll be $15,000, I'm sure. Much more profiteering on this side of the ocean. But you can see between here and here, the patient's progressing. Now, clearly there are areas that are getting better. So this area here, for example, there's less cord compression, but there's a new lesion here, there's a new lesion here, there's a new lesion here. And Moo said to you, if you have a new lesion, it's progression. So that's a new lesion, that's a new lesion, that's growing, etc. So when you say to your clinicians, they say, this patient's getting worse, they say, well, you know, I'm looking at this thing here called the PSA test, and it's getting better, and the patient feels fine. So what do? I keep pumping the same drug. And then what happens? So 3 months later, October to January, the patient progresses, right? You can see everywhere this has got worse, everything's got worse, except this area here. Even this is a bit worse. And now the patient is at this stage where he needs emergency radiotherapy. Not only that, but that will be a fatal event as far as this patient is concerned. So you've pumped in abiraterone now 9 cycles. You've spent a ton of money, $100,000. What's been the benefit? Now, there's an opportunity lost here, right? And the opportunity was presented at this point in October, but wasn't taken up by the clinicians. Part of that is they don't have anything else in the bag, right? And when Moo talks about treatment intensification, treatment modification, well, if you don't have anything else in your pocket that you can pull out, then, you know, it may not be that useful. So not only are we, there's another problem. We're also unable to identify many times when a patient is getting worse. As a result of which, patients end up with much larger volumes of disease, and that's a problem. So let me show you this example. So this is another guy getting enzalutamide again. This is again prostate cancer. You can see the bone scan is negative at the same time point. We've got some retroperitoneal lymph nodes. 13 weeks later, the PSA has gone down. Everybody's really happy. The DW-MRI has gone down. The bone scan is normal. Here we are at week 25. The MRI shows a lesion. So the patient is probably progressing, okay? But the clinicians are using bone scans. The bone scan is still negative. PSA is still suppressed. So what do? They do what they always do, which is, and they keep treating. You see what I mean? So here we go, week 37, 12 weeks more, 3 months more of treatment. Now I'm showing 1, 2, 3, 4, 5 lesions, and I'm now ringing the bell and saying, come on, guys, you need to change your treatment. Then they do a bone scan, and they say, oh, yeah, there are 2 new lesions. Actually, there are 5, but anyway. But they say, but we need to confirm this, because we're using the prostate cancer working 2 group criteria, and Moo talked about all these different criteria. This is what they're using. And so we need to confirm this before we can really be sure. Okay. So another 12 weeks goes by, and, yes, there are the 2 lesions you've confirmed are there, and there are a few more lesions. Okay. That's fine. And of course, the MRI is now showing even more disease. But the problem is, this is when we spotted the abnormality, that the patient was progressing. This is the point at which we actually change treatment. 25 weeks of a treatment that wasn't working. And then you know what they do? In the notes, they record that as the date of progression. Right? They say, actually, you progressed 3 months beforehand. So this is crazy stuff that goes on in the clinic every day. So how can we make this better? Now, clearly, in a bone marrow, we need to look at this space, and we all know that we have a great deal or number of tools that we can use to interrogate the bone marrow, for example. And I've just laid out some of the technologies that we can use and what they interrogate. Okay. Now, it's very clear that actually ADC alone is not enough. And that's why Mu showed you CT scans and bone scans and, all of these. So they're interrogating different parts of the same ecosystem. And by looking at different cameras at the same ecosystem, you can work out what's going on in a particular ecosystem. So, in fact, MRI, because of its flexibility, is able to be multimodal in its own. So diffusion imaging is just one of the armamentarium that we've got to be able to look at a complex space. And simple things do work. Now, so we have criteria on MRI for when things get worse. So I've just put these out here as pictorially, and we can, of course, describe and put words to these pictures, but I just show you a picture of something that gets worse. So here, for example, is here is post-treatment. You can see the PSA has gone up, so this time it's concordant. The patient's being treated with a hormonal therapy. And what you notice is a new lesion comes up, a new lesion comes up. There's soft tissue disease that's developing. This patient's developing cord compression, so this is emergent. If you don't do anything about this now, the patient will be paralyzed shortly. So, it's time to act. So this is an example of progression. And of course, it would be nice if everything just became normal. Wouldn't it be nice if things just became normal after treatment? But cancers, when they go away, they leave scars. And it would be great for cancers to do from that to that, but they don't. And let me show you an example of that sort of phenomenon. So here we go. Here's a patient who's actually getting better, being treated with chemotherapy in this particular instance. This is breast cancer. You'll see that on the T1, you'd think that was getting worse. So if you just had that scan, and you were using T1 rated imaging, which is what everybody uses in the clinic, you'd say the patient's getting worse. And then you might even be tempted to stop your treatment. But actually, if you just carry on, you'll see that the patient is responding. But the interesting thing you'll notice is that there are some lesions that just never go away. Right? That's a problem. These are scars that get left behind because there was a tumor there. For example, that particular vertebral body is collapsed, and that traditionally would have been called progression, but the patient's alive a year later. This wasn't progression. This is actually response. Okay? Now, why did the initial picture look worse? It looked worse because of the mechanism of cell kill. Now, if you kill a cell and you give chemo, then you tend to go down this pathway, and you get cellular death resulting in a tumor cell exploding and killing the neighbors. And there's an inflammatory component to this. So that's called a necrotic pathway, and sometimes it's nice to think of this as homicide. When you go and kill a lot of people, you have a big gun, you end up killing lots of people, so you end up killing up lots of cells. And that, of course, is quite different to apoptosis, or apoptotic cell death, which is more like cell suicide. Okay? So these novel targeted therapies that we talk about is actually suicide, whereas if you use chemo, domestos, that is more like homicide. Okay? And of course, on imaging, you can see the difference between homicide and suicide. Now, I'll show you that in a few minutes. So here's another example of a patient with prostate cancer this time. You'll see a new lesion appears, therefore progression. But what do you do here to here to here? This is a scar that's developed. So this is called arrested resolution. So this is another problem with morphological imaging. And you'll notice, for example, new lesions appearing and then becoming scarred. Now, so that means you can only detect progression when you have a new lesion on a virgin bone. Now, supposing you have an abnormal bone to start with, and then you get a new lesion on that. How do you deal with that? With morphological imaging, you just can't deal with that because it's all scarred. And I'll show you that in a second also. Now, to the rescue actually comes diffusion imaging. Diffusion imaging doesn't really care about scarring. It looks at cellular content of bone marrow, and here is the same patient. You'll see that between this time point and this time point, all we did was give radiotherapy to these two areas, but nothing else was done. And so this is the response to radiotherapy. Not great, but you see these lesions here, they all grew. So now, and the PSA has gone up, so we're happy to go forward and treat the patient. And you can see we treat with docetaxel, and after 10 cycles, after 4 cycles, the patient gets better, but you can't give chemo forever. You stop. What does the tumor do? It just comes back. Okay? Then you change treatment. This time you get a second type of chemotherapy called cabazitaxel, and again, it gets better. So you can see changes that occur in a background of scarring bone marrow quite effectively using this sort of technology. And of course, the change that you see is related to cell kill. And remember, we talked about 2 types of cell kill. We talked about cell kill that's related to suicide and cell kill related to homicide. Now, clearly, this is chemo. This is domestos. This kills and makes a big ADC change. And here is the histogram before, and here's the histogram afterwards, and you can see this is a big change. Okay. Now, the interesting thing is when you compare the diffusion imaging to the morphological imaging. So if you look at this example here, the same patient, the same 2 time points, you'll say between that and that, the diffusion shows it's better. But on imaging, on morphological imaging, this is what we all use in the clinic, we'd say this was worse. Next time, for the next exam, so between there and there, we would say on the diffusion, this is better. On here, we'd say this is better. Then what happens? Look what happens. After stopping the chemotherapy, the patient gets worse, and the morphology also shows worse. We switch treatment. Now we're treating with cabazitaxel. Between here and here, we say worse. Between here and here, we say worse. What about after 6 cycles of cabazitaxel? We say this is worse on the diffusion imaging, but between here and here, what do you say? Stable. So here, diffusion saying this patient is worse. On morphology, we're saying stable. And then we switch treatment. Now we're treating with abiraterone. You'll see this actually gets better. A lot of these things have gone down. Look at this. That's got better. That's got better. And here we say stable. Do you see how diffusion gives you a different answer compared to morphological imaging? And that's why we need diffusion imaging. Now, let's look at this patient here. Clearly, this patient is getting worse. There's no doubt about it. It just gets darker. There's more infiltration as we go along. So the question I've written here is, what happens to the bone marrow cellularity in tumor progression? Well, cellularity increases, correct? I mean, that's a no-brainer. You don't even need to do any measurements. And if you were to look at the B900 and the ADC maps, you would see increasing high signal, decreasing ADC, consistent with progression. Now, the interesting thing you can do is you can look at the T1 fat fraction. So if you look at the T1 fat fraction in the bone marrow at each of these time points, as tumor goes into the bone marrow, it displaces fat. This is what it should do, right? It shovels the fat out of the way, and so in the end you have decreasing fat and decreasing fat and increasing tumor. Now it turns out that if you just plot the ADC and the signal intensity in a segmented pelvis, for example, and here's the segmentation, and you just do a scatter plot, you get this sort of scatter plot where signal intensity goes along here and ADC goes along there, and by doing separate measurements in a yellow marrow, red marrow, and tumor, you can then define these thresholds. And you can work out that yellow marrow, generally speaking, has low signal intensity, low ADC, so it sits in this area. Red marrow has has an intermediate signal intensity, but a slightly higher ADC, and we know that tumor sits over here. And in fact, this is the 1500 value here. This is the sort of cell kill value that I use. Here you have high tissue water and low cellularity. So what would you, and you can actually calculate quite easily what are the proportions of the different voxels in these four areas. Now, so back to this patient over here, you can see that this patient gets worse. So if you just did the same experiment and just did those pixel plots again, you see how the ADC comes down, which is what you were visually able to see. And here's that 1500 cell kill value over here. Here's the signal intensity histogram, and you can see the signal intensity histogram increases. But this is the area we said the way you'd have viable tissue here. You can see it starts off at about 50%, goes to 70%, 70%, and 90%. So a simple way of visualizing the proportion of the marrow that is hypercellular in time. Now, if you did the reverse experiment, and maybe the patient was getting better, and here's a patient, again, with breast cancer. This patient is getting better. Here's the histogram. See, this is the prior histogram. This is the current histogram. So there's a shift to the right. Here's the 1500 value here, which if you look at this article written, I think Tom was an author on this particular article. You see this is the 1.5 value here, which is the same thing as that 1500 value that I use over here. Now, if you look at this patient over time, you can see that she gets better, and then about a year later, she's now beginning to get worse. Can you see new lesions here? So she's certainly improving for at least a year. Okay, now if you look at her histograms, you'll see the ADC histogram switches to the right, and you can see that happening there. So this is that 1500 value, so it's gone over the top. Then look what happens. It comes down, down, and down. So you've got this very dynamic shift of ADC going up, and then ADC coming down, and the signal intensity just goes down and down and down and down, which is what you expected just by the visual appreciation. Now, if you were to again measure the number of pixels in what I call the hypercellularity area, which is 90%, 30%, 19%, 15%, 6%. Another way to look at it is just look at these pixels, how they shift over to the left-hand side, and they move into these boxes over here. So all these pixels, which have been co-registered at each time point, have just moved over to the left, which is quite interesting. Now, why does this go down? Well, I've already shown you these images. This is related to the emergence of the fat. So as you cell kill, the histogram went to the right. As the repopulation of the normal bone marrow occurs, so the ADC comes down, and here you can see the re-emergence of the fat. So if you just put up, and you can of course quantify that using, again, your two-point Dixon technique. Here is the fat fraction, and you can see over time, for example, the fat begins to re-emerge into the bone marrow. Now, and here's the fat fraction shown over here. So here's the same histograms that I'd shown you before, a shift to the right, and then a gradual reduction over time. And you can see the fat fraction between here and here was just cell kill, but then as the fat begins to repopulate, you can see the fat fraction beginning to increase. But I did say to you that there is suicide and there is homicide. And can you see the difference between homicide and suicide? Well, I just wanted to show you an example of the same patient examined 11 times, in which we initially treated with a suicide type of treatment. Exemestane causes mostly apoptosis. Look at the signal intensity. Everything has been normalized to each other, and you can see how the signal intensity decreases over time. And then look what happens between here and here. You see how she relapses. One of the things I said to you yesterday, some of these treatments probably only work for about a year, and this is about a year. Look, this is May 2013. Here's June 2013, almost a year. You can see how she has a good response. Signal intensity goes down, but then she relapses. So then we switch to a chemotherapy. So this scan here is the same as that scan. This time we treat with a homicide type treatment, i.e. chemotherapy, but she develops toxicity in May, so we have to stop. And then she relapses. So we've got a nice example of a hormonal therapy followed by a chemotherapy. Now, if you were to just take the hormonal therapy to start with, if you looked at the T1 and the T2, what we use in the clinic every day, we'd go, no change, no change, no change, no change, no change. We're absolutely useless. And we still bill $1,000 for each of those useless examinations. Right? Nothing changes on T1, nothing changes on T2. Okay. let's see what happens when we change treatment. So we change treatment, we're now giving capecitabine. On the diffusion, we see it goes down. This is when the patient develops toxicity. Then she relapses, so we have to stop at this particular point. Let's have a look at our morphological imaging. T1 rated imaging is what we see, what we use in the clinic, and we go no change, no change, no change, no change, no change, right? I mean, how useless are we? We're still charging for these MRI examinations, right? But the interesting thing is on the T2, you do see a change. Can you see how the signal intensity goes up and then begins to come down? So there is a change, there's increasing tissue water that we can actually see on the T2 fat suppressed image. Now, if you don't do a T2 fat suppressed image, then you miss that particular observation. So that's why Mu and I, all of us prefer to do a T2 fat sat image. Now, if you were to do the histograms on this particular patient, you would see some really quite interesting things. So here is the signal intensity histogram. Here's that 1500 value, the cell kill value. But look how much that ADC increases. It's not a hell of a lot. Can you see that? It goes up, and then it comes down, and then we're back to where we started. Can you see that? At the end of treatment. So the histogram shift was actually pretty minor. Right? We do not see that much cell kill. Look at the chemotherapy, and you see quite a different phenomenon. Look what happens. The ADC goes up, and look, half the voxels are now over that 1500 line. But what happens? You can see what you see is, you remember the signal intensity decreased, and you can see the signal intensity of the ADC is beginning to come down, but look at the histogram. It's no longer ketotic. It's much wider. But when we stop, we're back to this situation. So not only do we see shifts in the histograms, but we're seeing changes in kurtosis. And these are dynamic changes, which is why David Collins, for example, introduced some of those concepts to you. And this is how you can see how they're valuable in the clinic to be able to work out what's happening. Now, let's look at the degree of cell kill. 95, we've got from about 100% infiltration. You know, hormonal therapy, about 60% infiltration. But if you go to chemotherapy, we go from 74% to 23%. That was the maximum cell kill. And then the patient relapses and goes back up to 65%. Okay. So what should we be using in the clinic for response assessment? What I say to my clinicians is, please don't do what you're doing now. They use pain-related criteria. They ask the patient, have you broken a bone? Are you getting more bone pain? And this is the craziest thing. They do this in the clinic all the time. We should be using more objective measures of looking at response. So, for example, look at this guy. He goes to the gym twice a week. Twice a week. His PSA is completely suppressed. He's getting treated with abiraterone, again, this expensive drug. Here we called it progression. The clinician said, you know, he goes to gym twice a week. He has no pain. The PSA, as far as I'm concerned, is suppressed. And I'm saying, but he has cancer that's increasing. They go, I don't care. What happens? Look. Between February and May, he's now walked into a court compression. I'm ringing the clinician and saying, what the hell are you doing? Not only are you wasting money, but you're wasting this guy's life. Because you're using PSA, which we know doesn't work in the castrate state. I'm telling you, I told you 3 months ago this patient's getting worse. Right? So we need to minimize patient harms. Now, the interesting thing about the diffusion is you will see this heterogeneity. So this is the same patient. You can see the patient gets better. So finally, we convince him to give radiotherapy. So he gives radiotherapy. But not only does this one get better, but actually the right shoulder gets better. So I rang him up and said, did you radiate the right shoulder? And of course, I didn't radiate the right shoulder. I just radiated the spine. And I said, well, the shoulder's better, but the left hip is worse. Right? So this is called the abscopal effect. It's quite well described in the literature, where you radiate something, you get an immune response, and some other lesion somewhere else gets better. But other lesions don't. So this is this heterogeneity that we were talking about, and this is something that David was alluding to, that you would be able to use some of these sophisticated tools to be able to look at these sorts of effects. Okay. I'm firmly convinced that we should be using imaging to assess treatment directly by looking at cell kill. We should look at cell kill. We should stop using progression criteria. And so in that case, diffusion imaging, I think, is the best way to do it because it's economical. But you know, FDG PET works, fluorocholine prostate cancer works. We don't really care. If it shows cell kill, then we should use it. And that's how we should be treating patients. So to just conclude, there are lots of treatment, for example, and I've just given you classes of treatment for metastatic bone disease. This is what we do at the moment. We say patients are better or worse. No, we don't say they're better or worse. We just say that they are not worse or they are worse. That's what we do in the clinic. We say no progression and progression. That's what we use in the clinic. With these new techniques such as diffusion imaging, actually we have the ability now to change that paradigm. It's a very simple thing that you guys need to do. All you need to do is to change progression, no progression, into 3 criteria: response, stable, and progression. And you know, clinicians will start thinking differently. If they start thinking differently, they start acting differently. So this is the only thing we really have to achieve. Thank you very much.